Good morning, colleagues, and thank you very much for the invitation to speak to you today. The topic under conversation is the surgical options in the treatment of cervical cancer. My name is Haynes van der Merwe, and I have no disclosures. Just by way of introduction, I'm a gynecologic oncologist, and I work at Tygerberg Academic Hospital in Cape Town. And on the slide, you can see a nice aerial picture of both the hospital and the university buildings at the hospital where I work. So when we talk about cervical cancer, I think it is important just to have a little bit of perspective. And I want to take you back to this call that came from the WHO only about 5 years ago that set the targets of the global strategy to accelerate the elimination of cervical cancer. And the targets include vaccination of 90% of eligible girls against HPV, the screening target of 70% of eligible women at least twice in their lifetimes, and then also to effectively treat those with either a positive screening test or who already have a cervical lesion, and that obviously includes palliative care for those who might unfortunately have presented at a very late stage. I also just want to remind you about the histologic types that we get of cervical cancer, squamous and adenocarcinoma, obviously by far the most important, but then don't forget the rarer histologic types that I've listed here on this slide. We don't see them that often, but the important thing about the rarer histologic types, they are often very aggressive type of tumors, and one needs to individualize treatment. Just a few general considerations about the management of patients with cervical cancer. I think it is important to centralize care of these patients in specialized centers. My view is also to have a multidisciplinary planning of treatment, if at all available. This is what we do in our unit, where not only us as gynecological oncologists, but also the clinical oncologists get together once a week to discuss patients. And then once you deal with a patient, to have a careful and comprehensive approach to counseling of the patient. And of course, the treatment should be by a dedicated specialist team, which in my mind should include the services of a gynecological oncologist. Just a few words about the clinical and diagnostic workup. This is now once a patient has been diagnosed with cervical cancer. I don't think we can move away from a comprehensive clinical examination of the patient, especially where I work in South Africa. We're a lower middle income country, and many other regions in the world, the majority of Africa. I think the first step is to examine your patient thoroughly, and that should include a pelvic examination with full assessment of the pelvis. This examination is obviously to look for any findings or signs of metastases outside of the cervix. If you have the luxury of access to MRI scanning, I think one can use MRI. We use it in our unit in patients who present to us with fairly early disease. I don't think it has a lot of value in patients with locally advanced disease. And if you don't have pelvic MRI available, I think ultrasonography in experienced hands are also very good. We should image the chest, the lungs, and the abdomen. You can include cystoscopy if you want to exclude bladder invasion. We've stopped doing that for all of our patients presenting with cervical cancer. Only if they have hematuria, we will follow that up with a cystoscopy. Nodal disease will, in early disease, be surgically, pathologically staged. And I think any equivocal extrauterine disease should be biopsied or FNA. So if you feel enlarged nodes supraclavicularly or inguinally, I think it is imperative to do either a biopsy or a FNA of those nodes. Just to remind you about the new staging, the stage 1A, which is regarded as microscopic disease, which is further divided in 1A1 and 1A little 2. The new or the latest staging of cervix cancer, the 1B category is subdivided in 1B, 1, 2, and 3, depending on the size of the tumor. And then patients with stage 2 disease might also be considered for surgical management. So I'm swiftly going to move now to the surgical management of the early stages. And just if I can make a general comment here as well, as far as treatment goes, we've got 2 treatment modalities available for patients with cervix cancer. The one is surgery and the other one is radiotherapy, sometimes with addition of chemosensitization. And as a general rule, patients will qualify for surgical treatment if the disease is confined to the cervix. Any locally advanced disease, those patients should not have surgery and should have chemoradiation. So if we can just subdivide the stage 1 disease in 1A little 1 and 1A little 2, the majority of patients with stage 1A little 1 disease are LVSI negative, because we know in the first 3 millimeters of the cervical stroma, there is hardly, or there are hardly any lymphovascular space. So it is infrequent to find these patients to be LVSI positive, but we do find them from time to time. So the majority will be LVSI negative, and these patients do not need any further surgical assessment of their lymph nodes, and they can either be treated by a simple conization, or I think if a patient's family is completed, a simple hysterectomy. And the recommended route is a vaginal hysterectomy. I think is doable. Patients who are LVSI positive in stage 1A little 1, I think should be treated the same as 1A little 2, and they need surgical assessment of their lymph nodes. If sentinel lymph node biopsies, if that is available in your unit, you can use that. If not available, I think you should do a full pelvic lymphadenectomy. 1A little 2, the management of the primary tumor, I won't say is controversial, but there is some contention about it. In our unit here in Cape Town, the 1A little 2s for the primary tumor, you can either, if you embark on fertility sparing treatment, I think a simple cone is sufficient. Again, the patient whose family is complete can have a simple hysterectomy, but I know there are many units that will propose these patients to have a modified radical hysterectomy. In our unit, we, as I say, do simple hysterectomy, and we find that to be sufficient as the approach to the primary tumor because of the risk of lymph node involvement. In patients with stage 1A little 2, I think they need assessment of the lymph nodes, surgical assessment. Again, if you have sentinel nodes available in your unit, you can do a sentinel node. If not, I think a proper pelvic lymphadenectomy is to be done. Let's move on to the stage 1Bs. Again, I think there would be different opinions about the various subcategories of stage 1B. I think there would be agreement amongst most colleagues that 1B1 and 1B2 should be treated by or surgically. There might be some discussion about the 1B3s, the tumors bigger than 4 centimeters, the big 1Bs. We know their risk of having adjuvant treatment is also a little bit higher, and therefore some units will say primary radiotherapy, but I think those patients can be treated surgically. So the surgical option for these patients are a radical hysterectomy, and we'll have a look just at the various types of radical hysterectomies as we go along. I'll show that in the next slide. And again, if you have sentinel lymph nodes available, you can do a sentinel lymph node. A controversial area in these patients will also be if they are node positive. So if you have access to an MRI or good imaging of the pelvis that indicates the possibility of positive nodes, some people will first go in and do a proper surgical assessment of the nodes, surgical and pathologic assessment of the nodes. You can either do it as a procedure, a single procedure, or at the start of the radical hysterectomy, if you have the pathologic services available in your hospital, to come to theater and do a frozen section, remove the nodes the suspicious nodes, and if they are positive, some people will say that this patient will in any case need adjuvant radiotherapy, and you should abandon surgery and give the patient treatment. There is some controversy. Some people will say, no, let's continue with our surgery. At least we get the tumor out, we get all the nodes out, and there's less to irradiate post-operatively. Then just a few words on the types of hysterectomy, simple extrafacial hysterectomy, modified radical hysterectomy, and then the proper radical hysterectomy. On this slide, I just want to show you the different classifications, the Piver and Rutledge classification, the Querlu and Morrow classification, and at which stages the different types of hysterectomies are indicated. And then just the comparison is really about how much vaginal cuff you take. Firstly, with a simple hysterectomy, there's no cuff taken. With the radical hysterectomies, at least 1 to 2 centimeters of cuff is taken. The ureteric dissection is not really indicated or necessary in a simple hysterectomy or extrafascial, but then mobilization of the ureters and to mobilize them laterally out of your field to get access to the parametria is definitely part of the either modified or type 2 or type 3 radical hysterectomy. Again, also the extent to where you dissect the cardinal ligaments differ between the two types of radical hysterectomy. As the same applies to the uterosacral ligaments. The bladder is mobilized to the upper or middle vagina in the case of the radical hysterectomy, which is not really necessary in extrafascial hysterectomy, and the rectum is also mobilized to way below the cervix in a radical hysterectomy. Colleagues, just a few words on adjuvant treatment. We do have to accept that probably between 10 and 15% of our patients that we have preoperatively assessed to be surgically treatable will require adjuvant, either just radiotherapy or chemoradiation. And we divide those indications into major and minor criteria. So any patient with positive lymph nodes, positive margins, or parametrial involvements regarded as a major criteria, any one of those positive, that patient should have radiotherapy, and definitely if there is lymph node involvement, the addition of chemosensitization is paramount. Then there are the so-called minor criteria, looking at the depth of invasion, whether there's lymphovascular space invasion, and any two of the minor criteria being positive will also be regarded as an indication for adjuvant treatment. I think we just have to say something about fertility-sparing treatment as well, because some of the patients referred to you will be young and will desire future fertility. Now, the patients that qualify for fertility-sparing treatment should be very well selected. First of all, fertility-sparing treatment does not apply to any of the rare histologic types. Patients should either have a squamous or adenocarcinoma, which is HPV associated. Any other rare histologic types do not qualify for fertility-sparing treatment. Then the patient should have radiological assessment of lymph nodes. If there is clearly pathological lymph nodes on radiological assessment, again, they don't qualify for fertility-sparing treatment. If they aren't, then we look at tumor size, and only patients with tumors smaller than 2 centimeters would qualify for fertility-sparing treatment. Those who are then assessed to qualify for fertility-sparing treatment will the surgery will start with intraoperative assessment of the lymph nodes. So and there again you should have the pathologist in theater with you to do a frozen section. If unfortunately the patient has positive nodes, that patient does not qualify for further surgery and should have definitive chemoradiation. Patients who are lymph node negative, one will then decide about the extent of the surgery of the primary tumor based on the size of the tumor. Patients with 1A disease is a simple conization should be fine. Stage anything more than that should have a trachelectomy, which could either be a simple or a radical trachelectomy. Then just a few words about what do we do with patients who now had a simple hysterectomy. We find that sometimes patients are referred to us. They've now had a simple hysterectomy with undiagnosed cervix cancer preoperatively, but now it comes back. So anything more than a 1A little one, the patient needs to be properly assessed, and a decision should be taken about the assessment of the nodes. The challenge here is, well, you've got two options. You can either go back and do a proper lymph node assessment. That means a pelvic lymph node dissection with or without the parametrectomy, because if the patient has negative nodes and the parameter is clear, she does not require any further treatment. Whereas your other treatment option is to just irradiate all of them, but that will mean that you will probably irradiate a lot of patients unnecessarily. So my recommendation is to go back, go and do a pelvic lymph node dissection and decide whether the patient really needs a trachelectomy. We hardly ever do a trachelectomy, but assessment of the lymph nodes is very important. Cervical cancer in pregnancy is obviously a whole big topic on its own. But again, just the patients whom you diagnose in pregnancy with a cervical cancer, who at that stage you feel is surgically treatable, but the patient is not yet at fetal viability. We would carefully counsel those patients, and they have to decide whether they want to proceed with the pregnancy or not. So if they don't desire to proceed with the pregnancy or continue with the pregnancy, then you can terminate the pregnancy and then treat them with whichever form of treatment you think is appropriate. In early stage disease, most likely a radical hysterectomy. If, however, the patient decides to continue with the pregnancy, we would follow a fetal maturity approach. In other words, we will continue or allow the patient to continue with the pregnancy, but she will in the meantime receive chemotherapy. They will either get single agent platinum or platinum plus Taxol at 3 to 4 weekly intervals. And then I think by 34 to maybe 36 weeks, you should take a decision to then deliver the baby, and at the same stage, at the same time, do a radical hysterectomy and pelvic lymph node dissection. Lastly, colleagues, a few words about recurrent disease. We from time to time see patients who present to us with disease recurrence after chemo radiotherapy. Those patients needs a very, very comprehensive and thorough assessment. First of all, to establish that the recurrence is only central and that the patient does not have any disease outside of the cervix. For those with central disease, I think a patient qualifies for pelvic exenteration. There are braver surgeons amongst us who will even attempt surgical treatment of the patients with pelvic sidewall extension of disease, the so-called Lear procedure. But we do not do that in our unit. Patients who have a recurrence after primary surgery, who have not had adjuvant treatment, can then be managed by chemoradiation. Colleagues, that is what I had to say about the surgical treatment of cervical cancer. I know that was a whirlwind tour through the topic. But thank you for your time. Thank you for listening. And just I want to remind you about the FIGO Congress that will be in Cape Town from the 5th to the 9th of October. It's 5 weeks from now. And I want to use this opportunity to invite all of you to come to Cape Town. I know it is a little bit late, but you can still register, book your flights, get your visa in order, and please come and join us in Cape Town. I'm personally looking forward to meet a lot of you in Cape Town, as I'm the co-chair of the local organizing committee. So a warm invitation and a warm welcome to all of you, and I hope to see many of you in Cape Town. Thank you very much, and enjoy the rest of this meeting.
It's on. Thank you, Dr. Haynes.